Imagine an exercise that is so universally recommended for physical recovery that doctors actually prescribe it to you, right? But then at the same time, it is so anatomically brutal that it can literally drop the blood oxygen in your pelvic tissue by over 80%.
Yeah, it sounds completely made up, but it's not.
It's totally real. And welcome to the deep dive, everyone. Today's mission is tackling a really specific yet honestly universally relevant question for anyone who loves biking but has, recently gone through a major physical event. And that question is, how soon can I resume cycling?
Right. And to figure this out, we've pulled together a massive stack of source material for you
Oh
today.
yeah, huge stack. We've got clinical medical guidelines, physiotherapy protocols, and some incredibly dense cycling biomechanics research.
And the funny thing is, the deeper you look into this literature, you realize there's this massive contradiction just staring right at us.
Yeah, it's wild. The clinical guidelines and the biomechanics data are basically speaking two completely different languages.
Exactly. On one side, you have the medical establishment, right? And they are celebrating cycling as like the ultimate low-impact cardiovascular recovery tool.
Which makes sense on the surface.
Sure. But then you turn to the biomechanics sources, and they frame the traditional bicycle saddle as this major, almost existential threat to pelvic floor health.
It's completely wild. So, answering the question of how soon you can get back on the bike requires navigating that exact contradiction.
Yeah, it's not just about, circling a date on a calendar. It is fundamentally about understanding the complex physics between human anatomy and the actual machine you are sitting on.
So, to make sense of this, let's start with segment one, the healing timelines. Patience before pedals. Before we even look at the bike, we really have to look at the body's baseline healing process.
Absolutely. Because whether you are recovering from a vaginal delivery, a C-section, or, a major gynecological procedure like a hysterectomy or pelvic floor repair, the sources are incredibly strict about the first 0 to 6 weeks.
Super strict.
Yeah, that 6-week window is the non-negotiable biological baseline. During this phase, the tissue remodeling process is, well, it's basically in its infancy.
Right.
Your body has experienced significant trauma, and the fascia, that's the connective tissue holding everything together, has practically zero tensile strength at this point.
So, you really can't push it at all.
Not at all. The guidelines restrict activity to gentle walking and basic unweighted pelvic floor exercises, like Kegels. And the physical lifting restrictions here are paramount.
Oh, the lifting restrictions really put it in perspective for me.
Yeah, you are advised to lift nothing heavier than your baby. And for surgical patients, the limit is often capped at a strict 1.5 kilograms.
Okay, let's unpack this for a second because 1.5 kilos is, that's barely a full kettle of water.
Exactly.
It really paints a picture of just how fragile that internal scaffolding is during those first few weeks. Obviously, throwing your leg over a bicycle frame is completely out of the question here.
Oh, 100%. But let's say you hit that 6-week milestone, right? Your doctor gives you the green light for light exercise.
The magical 6 weeks.
Right. But the sources are very specific here. This return needs to happen on a stationary bike, not out on the road.
Which kind of sounds boring, but there's a really good medical reason for it, right?
There is. The stationary bike removes all the unpredictable variables. When you are riding outdoors, you're dealing with sudden stops, balancing, swerving around potholes.
Bracing against the terrain.
Exactly. All of those micro adjustments require rapid, intense contractions of your core and pelvic floor muscles.
And at 6 weeks, you just can't do that.
No, your tissue literally cannot handle those sudden spikes in intra-abdominal pressure. So the stationary bike provides this controlled, predictable environment to start spinning the legs again.
Okay, so when can you actually get back out on the road?
For actual outdoor riding, especially if you want to tackle hills or rough terrain, the body needs a minimum of 12 weeks. It takes that long to rebuild enough tissue density and strength to absorb those forces safely.
And we should definitely note that this timeline stretches out way further if you experienced a severe tear during childbirth. The sources go into a lot of detail about OASI, which stands for obstetric anal sphincter injuries.
Yeah, OASI encompasses third and fourth degree tears. And just to understand the severity here, a third degree tear involves the anal sphincter complex, and a fourth degree tear extends completely through the sphincter and into the lining of the rectum.
Ugh, that sounds incredibly painful.
The tissue trauma is profound. The physiotherapy protocols state that for these patients, simply sitting normally on a soft chair is agonizing for the first 4 to 6 weeks.
Wow.
So straddling a narrow wedge of a bicycle saddle that is completely off limits until you are explicitly evaluated and cleared by a specialized pelvic health physiotherapist.
So just to give you an analogy here, think of your healing pelvic floor like a woven hammock, right? It's just been surgically repaired or stretched to its absolute limit.
That's a great way to picture it.
You wouldn't immediately throw a heavy bowling ball into that hammock while the threads are still fraying. It takes time for that repair to strengthen. And if you take that fragile hammock and stretch it tightly over a hard, narrow wedge, which is basically what a bike saddle is, you're just going to pry that delicate repair right back open.
Yeah, that visual captures the mechanical threat perfectly.
Mm-hmm.
You are dealing with an upward wedge prying against a downward healing structure.
So let's assume you follow all the rules. You wait the full 12 weeks, the tissues have knitted back together, the doctor clears you, and you finally get back on the saddle. But you still feel this shooting pain or a severe, really uncomfortable numbness.
Which happens a lot.
Right. And that tells us the problem isn't just about the timeline of tissue healing anymore, is it?
No, not at all. It's about the geometry of what you're actually sitting on. Which brings us to the physics of the saddle.
Yeah, let's get into the actual anatomy of this, because the clash between the human pelvis and the traditional bike saddle is just wild. What is biologically happening when we sit on a bike?
Well, it starts with the simple fact that the tissue interacting with the saddle was never meant to bear weight. The human body is designed to sit on the ischial tuberosities.
Okay, meaning?
Those are the two bony prominences at the base of your pelvis. We commonly call them the sit bone.
Right, sit bones, got it.
But a traditional bicycle saddle is often so narrow or shaped in such a way that those sit bones just slide right off the sides.
Oh, so you're not even sitting on the bones.
Exactly. When that happens, your entire upper body weight bypasses the skeleton entirely, and it's driven directly into the perineum. That's the soft tissue located between the genitals and the anus.
And that soft tissue is essentially a major biological highway, right? Like it's not just muscle and fat down there.
Far from it. The perineum houses the pudendal neurovascular bundle.
The what bundle?
Pudendal neurovascular bundle. It is the primary nerve and blood supply for your entire pelvic floor and genital region. So when you sit on a traditional saddle, you are trapping that bundle.
Okay, trapping it against what?
You have the immovable pubic symphysis, that's the hard bone at the front of your pelvis, acting as the top of a clamp.
Mm-hmm.
And the hard nose of the saddle acts as the bottom. So the nerve and the blood vessels get completely crushed between them.
Ouch.
Yeah. And the clinical literature actually demonstrates that under this exact compression, penile or perineal blood oxygen levels can drop by over 80%.
Wait, hold on. Over 80%?
Over 80%.
If the blood oxygen in my arm dropped by 80%, it would go completely dead. I'd be in agonizing pain and I'd be in the emergency room immediately. How is this not considered a massive medical crisis? I mean, why isn't every doctor telling patients to stay entirely away from bicycles if it's literally suffocating the tissue?
You know, you've hit on a major cultural blind spot in the sporting world there. Because cyclists have historically just normalized this trauma. They categorize it under the no pain, no gain mentality of endurance sports.
Just tough it out, right?
Exactly. But neurologically speaking, that numbness isn't a badge of toughness. It is literally your body screaming that it is experiencing tissue ischemia. You are cutting off the oxygen supply to the cellular structure. And over time, this leads directly to what the medical literature formally categorizes as bicycle saddle diseases, or BSDs.
BSDs. So what does a bicycle saddle disease actually look like in practice? Because a drop in blood oxygen has to have serious long-term consequences.
Oh, it does. It encompasses a wide, often chronic spectrum of issues. For men, the primary concerns are chronic numbness and erectile dysfunction.
Yay.
Yeah. And for women, it manifests as severe vulvar pain, labial fibrosis, which is the thickening and scarring of the tissue from constant microtrauma, and recurrent urinary tract infections.
That sounds miserable.
It is. And the data is striking here. Up to 91% of cyclists experience some form of significant saddle discomfort or numbness at some point in their riding history.
91%. Okay, but wait. If 9 out of 10 people are experiencing this ischemic crushing of their nerves, what is going on with the other 9%? Are they just lying about being numb?
No, you're not lying. The sources highlight this fascinating subset of the population when it comes to human anatomical variants.
The lucky few.
Yeah, exactly. Roughly 20 to 30% of people are effectively the resilient few. They actually possess an anatomical quirk that protects them.
Like what kind of quirk?
For instance, their pudendal nerves might run deeper inside a protective bony groove in the pelvis, or they might have an exceptionally thick layer of protective fascia that acts as, like, an internal shock absorber.
Oh, I see.
So when they sit on a saddle, the pressure doesn't clamp down on the nerve in the same way.
That makes total sense, but it's incredibly frustrating. Because the people who historically design these saddles, or the seasoned riders who tell you to just tough it out because they ride 100 miles a week without issue, they might literally have a different pelvic bone structure than the rest of us.
Exactly. They aren't tougher, they're just anatomically shielded.
Wow. Shielded from the mechanics of the clamp, while the rest of the population is just forcing a fragile, unshielded soft tissue structure against a wedge of carbon or firm foam and paying a severe medical price for it.
That is exactly what's happening.
Okay, so that realization leads us to what is perhaps the most counterintuitive part of all the sources we looked at today. Segment 3, the prolapse paradox.
Oh, this part is fascinating.
Right, because we've just established that the saddle acts like a clamp, suffocating the tissue, crushing the pudendal nerve, and causing widespread damage for a huge percentage of riders. And yet, multiple physiotherapy protocols explicitly recommend stationary cycling for women who are actively recovering from pelvic organ prolapse.
They do.
That sounds entirely backward. I mean, how can something that damages the pelvic floor also be prescribed to heal it?
To unravel that paradox, we really have to look closely at the mechanics of pelvic organ prolapse. Prolapse occurs when the hammock of muscles forming the pelvic floor weakens to the point that it can no longer support the internal organs.
So things start to drop.
Unfortunately, yes. The bladder, the uterus, or the bowel begin to slip down into or even out of the vaginal canal. And in this state, gravity becomes the absolute enemy of the healing process.
Because gravity is providing a constant downward pull on organs that have completely lost their foundational support.
Correct. This is why high-impact exercises like running, jumping, or even brisk walking are heavily restricted for prolapse patients.
Makes sense.
Right, because every time your foot strikes the pavement, the impact sends a shockwave up your leg, and gravity pulls your internal organs down like a hammer hitting that weakened pelvic sling. Yeah. The downward force actively worsens the prolapse. Cycling, however, is a low-impact sport. Your feet never strike the ground. But more importantly, the bicycle seat provides an opposing mechanical force.
Here's where it gets really interesting for you listening. The very thing that is pressing up and crushing the pudendal nerve is also pressing up and physically blocking the organs from dropping further. It acts almost like an external splint or scaffolding, right?
That is the mechanical trade-off, exactly. While the saddle might compress the perineal tissue, for a prolapse patient, it physically holds the pelvic organs in place from the outside.
It's acting as a structural ally.
Exactly. It directly counteracts gravity. And this provides a profound benefit because it allows these patients to achieve high-intensity cardiovascular workouts. They get the blood flow, the metabolic health, the weight loss, all without the danger of dragging their pelvic organs further down.
So the saddle becomes an anatomical ally for the prolapse, even though it remains a threat to the pudendal nerve. It really highlights how dangerous blanket medical advice can be.
Oh, absolutely.
If you have a repairing third-degree perineal tear, that upward pressure is your worst enemy. But if you have pelvic organ prolapse, that exact same upward pressure is a tool for freedom.
It entirely depends on the specific geometry of the trauma you are recovering from, which actually brings the conversation to application our fourth segment, hacking the ride.
Right. Since cycling exists as both a risk and a highly recommended recovery tool, how do you safely modify your setup to protect your healing body? The sources devote a ton of space to this.
They do. And the primary directive across all these biomechanics blogs is that fitting the bike to your body is infinitely more important than buying expensive gear.
Bike fit over gear, always.
Always. And the golden rule they all emphasize is the angle of the saddle. It must be perfectly level.
Perfectly low. Like get a tool out level.
Literally. The sources recommend taking a spirit level from your toolbox and placing it right on the seat. The physics here are incredibly sensitive. If the nose of the saddle is tilted upward by even 1 or 2 degrees, just a tiny bit, it acts as a lever.
And what does that do?
It dramatically increases the localized pressure driven directly into the perineum and the neurovascular bundle.
But it's not just the seat angle, it's also where your hands go, right?
Right.
Handlebar height plays a massive role in what happens to your pelvis.
It really does. Handlebar height essentially dictates your pelvic rotation. If your handlebars are too low, you are forced to stretch forward and down to reach them.
Like in an aerodynamic racing tuck.
Exactly. And this physical reach forces your body into an interior pelvic tilt. Essentially, your hip bones roll forward. When that happens, your sit bones rotate up and away from the wider part of the saddle, and you drag all of that soft perineal tissue forward.
Crushing it directly against the narrow nose of the seat.
Yep. So raising the handlebars allows the rider to sit more upright, rotating the pelvis backward, and placing the skeletal weight firmly onto the sit bones where it belongs.
Okay, so you've leveled the seat and you've raised the handlebars to fix your posture. What does the literature actually say about the saddle itself? Because you probably shouldn't just use the stock one that comes with the bike.
Usually not. The saddle geometry needs to remove the pressure points, so the sources strongly advocate for female-specific saddles featuring central cutouts. Brands like Solitalia or ISM are frequently highlighted in the literature.
And these cutouts just remove the material.
Yeah, they physically remove the material right in the center where the pudendal nerve sits. It creates a channel for the soft tissue to rest without being compressed against a solid surface. Furthermore, the use of padded cycling shorts, the chamois, is practically mandatory.
Ah, the chamois. And we have to highlight the cardinal rule of wearing a chamois for you guys absolutely no underwear.
None whatsoever, please. The chamois is engineered to sit directly against the skin. Wearing underwear introduces seams and cotton fabric between your skin and the padding.
And that's bad because
Those seams create intense friction and cotton traps moisture. Together, they create the absolute perfect environment for severe saddle sores, bacterial infections, and skin breakdown.
Speaking of skin breakdown, there is a fascinating lesser-known detail in the sources regarding postnatal recovery that honestly blew my mind.
Oh, the hormonal blind spot.
Yes, the physiological changes that happen if you are breastfeeding completely alter how your skin reacts to the saddle.
It's a critical piece of medical context, and it is tragically under-discussed in cycling circles. When a postnatal woman is breastfeeding, her body naturally suppresses the production of estrogen. This creates a systemic low estrogen state that actually closely mimics the biological environment of menopause.
And estrogen is what keeps the tissue elastic, thick, and durable, right?
Exactly. Estrogen is vital for tissue health in the pelvic region. Without it, the vaginal and vulvar tissues become friable, meaning they are physically thinner, far less elastic, and lacking natural lubrication.
So they're super delicate.
Highly vulnerable on a cellular level. So for a breastfeeding cyclist, the normal friction of a bike saddle, which might have only been a minor annoyance before her pregnancy, can suddenly shear the skin. It causes severe abrasions, microcuts, and deep saddle sores.
So what can you do about it?
The sources emphasize that riders experiencing this should consult their doctor immediately because topical estrogen creams are sometimes utilized to restore that localized tissue health during the breastfeeding phase.
That is such a crucial aha moment. Because if it suddenly hurts more than it used to, it's not just that you're out of shape or your bike fit changed, your actual cellular structure is different.
Exactly. It's a biological change.
Okay, let's talk about one more adjustment riding posture during a workout. Usually, the conventional advice for a rider
Because of the intra-abdominal pressure we discussed earlier. Standing up out of the saddle to pedal is not a leg exercise. It requires a massive, sustained contraction of your core abdominal muscles to stabilize your entire body over the bike.
Oh, I see.
Yeah, and that intense core engagement creates a severe spike in downward intra-abdominal pressure. If your pelvic floor is still healing from childbirth, a hysterectomy, or if you have a prolapse, that spike in downward force acts just like the high-impact running we warned against earlier.
It just shoves everything down.
Exactly. It can severely compromise the healing tissue or force the organs further down. For these riders, the protocol is crystal clear. Keep the resistance manageable, do not stand a sprint, and keep your weight supported by the saddle.
So to safely navigate all of this, you have to level the saddle to avoid the upward wedge, raise the handlebars to fix the anterior pelvic tilt, get a cutout saddle to protect the nerve, wear the chamois without underwear, be deeply aware of your estrogen levels, and stay seated to protect your internal repairs.
It's a lot to manage.
It is. But what happens if you do all of that? Say you spend the money on a professional bike fit, you buy the creams, you follow the posture rules, and you still experience agonizing numbness or pain. What then?
Well, when the traditional diamond frame bicycles simply cannot be reconciled with your anatomy, the sources point to a radical alternative. Which brings us to segment 5.
I found this section of the research so interesting because it forces us to challenge the very definition of what a bicycle is supposed to look like.
It really does. The biomechanics literature highlights the use of recumbent bicycles. They specifically cite models engineered by companies like Cruise Bike, like their V20C or S40 frames.
For you listening who might not be familiar, a recumbent bike completely changes your orientation. Instead of leaning forward over the handlebars, you are sitting back, almost like you're reclined in a lawn chair or, the driver's seat of a sports car, with your legs pedaling out in front of you.
And that geometry changes everything about weight distribution. By shifting the rider into a laid-back, forward-facing posture, the pelvis is rotated entirely away from the perineum.
So you aren't straddling a narrow wedge anymore.
Exactly. You're actually sitting in a seat. Your body weight is now supported 100% by your gluteal muscles and your back. The upward pressure on the pudendal neurovascular bundle is not just reduced by a few degrees, it is entirely eliminated.
That is incredible.
By removing the compression mechanics, you literally eradicate the risk of bicycle saddle diseases. The threat of urinary tract infections, erectile dysfunction, vulvar pain, and tissue ischemia drops to absolute zero.
So for someone recovering from major pelvic trauma, this is a game changer.
It's huge. The recumbent geometry allows them to completely focus on the cardiovascular and mental health benefits of the sport without constantly gambling their physical recovery.
So synthesizing everything we've looked at today, what does this actually mean for you, the listener, if you are looking at your bike and wondering when you can ride again? It is ultimately a massive balancing act.
It really is.
Answering the when requires deeply respecting the timeline of human tissue, giving that biological scaffolding the strict 6 to 12 weeks it needs to build tensile strength. But answering the how requires respecting the physics of your own anatomy.
Because your pelvic floor is a fragile, dynamic structure.
Right. You have to be willing to modify your equipment, understand the cellular changes in your body, and adjust your posture to protect it.
It really just comes down to equipping yourself with the mechanical knowledge of how these forces interact.
Yeah.
So that you aren't unwittingly fighting a war against your own biology.
And as we wrap up this deep dive, there's one final lingering thought from the research that we want to leave you with.
Yeah, this is something that really stuck with me. When you consider that the traditional diamond frame bicycle and its accompanying saddle were designed over a century ago,
Right.
and that the modern clinical data proves they fundamentally clash with human pelvic anatomy for up to 80% of the population, it forces a much broader question.
Which is,
Are we stubbornly forcing our bodies to adapt and suffering through completely preventable medical crises just to fit a flawed machine? Or is it finally time we start demanding that our machines adapt to the reality of our bodies?
that is definitely something to chew on the next time you look at the bike sitting in your garage. Thank you so much for joining us on this deep dive. Keep learning, stay curious, and most importantly, listen to your body. Catch you next time.